we're not going to talk about anything except one thing, home induction. First of all, there's 5 products out there. There's really actually some more products. We're not talking about them right now. Only one I've got, a Suboxone, the most common thing. That's kind of the Cadillac. You've got 2 generic tablets, a white one and an orange one. Patients will have a preference. I like the orange, but I don't like the white. No give a reason. Okay. And the Belbuca goes in the cheek, very nice. Subzolve, Humana, I believe, is the insurance company, insists you use Subzolve. It sucks. The conversion dosage is 5.7 to 8 milligrams, and that is not even close. You just about have to always give them at least 8 or even more of Subzolve, so it's not that. Their conversion was for marketing and sales. I'm very disappointed. People say, can I use Butrans? Well, you're talking about less than a milligram. So that's a patch that you can put on for a week. Okay, here's what we do. This overall schedule, we used to have 16 as our maximum for induction, home induction. Now we've moved it to 12. We find, and you say, well, some of my patients maybe are addiction, they're street people. At Lifeline, we're now using 12 as the standard. These are people with IV heroin and everything else. Endocarditis, heart valves, the whole thing, and 12 is working on most. So it's first visit. Second visit, if it's a stable person with a stable background, and probably a pain patient, we'll recheck them in 2 weeks. We'll dispense number 21 of them, of the 8 milligram, and we'll say, when you come back, you'll either be on maybe 1 film or a film and a half. That's their instructions. You tell me which it is when you get here. We'll see you. If it's an unstable kind of, I'm not sure how much I trust them, rechecks in 1 week. Third visit. If they're stable, move them to 1 month. If they're unstable, we might go for 1 week. Most likely we'll go to a 2-week schedule, and then we move them up to a month. The maximum we'll do is a 3 months after they've been with us, maybe half a year to a year, something like that. Okay? So that's kind of the schedule we'll use. Okay? Our longest we'll see them out is 3 months. I only have 1 patient that we allowed to go further than that, and that's we do him on a 3 times a year because he's in Brazil and he flies up from Brazil to get his prescriptions and he flies back to Brazil. They don't have Suboxone in Brazil. Weird. It's the furthest patient I've got. Let's talk about methadone for a moment. Patients are going to come to you on methadone and they'll come in and say, I want to get on Suboxone. So well, here's a kicker with methadone. It's long, drug-out half-life. Okay. It's a pain. What we do, if it's a pain patient, this is what I do. Now, I'm not saying this is what you should do. I'm just telling you what John Hart, tonight is letting you walk through my clinic with me. This is what I do, okay? They're a pain patient. We're not talking about addiction and other stuff. They're on methadone by maybe their family doctor, something for the treatment of their back pain or whatever it may be. We'll switch them over to a morphine preferably, or maybe over to oxycodone for 1 month to treat their pain. We'll then give them a prescription at the very same time for Suboxone along with induction instructions for home induction. The home induction is fairly simple. As it says, I hope on the handout you got, it says you simply go ahead and take, there's 3 parts to it. One is technique, and we're going to talk about this in a moment. Under the tongue, hang your head down, don't look up, don't talk. For the film, it's 5 minutes. For the tablet, it's 10 minutes. Why don't I look up? Why don't I talk? Because it's only absorbed in the mucosa in the front part of the cheeks and under the tongue. So if I'm talking to you and I'm walking around and we're looking around the room, in 5 or 10 minutes, I'm going to swallow a dozen times. And when I do, I swallow the Suboxone, and there are no receptors in the stomach. So I effectively spit it out. So if I swallow Suboxone, it's the same as spitting it out. So we make sure, head down, do that. Second point, dissolving does not mean absorption. Stuff, the film will dissolve in about a minute or 2. One of our patients the other day said, this is 30 seconds. Wow, that's fast. And we put it on the tongue, hang your head down. Because it's dissolved, it is not absorbed. You go by your watch or your cell phone nowadays, and you time yourself. 5 minutes, 10 minutes. You can have greater than that if you wish. But that's the basic place to start with. You start then, so you take your narcotic the night before, except methadone. Next morning, you get out of bed, don't take anything, put yourself into withdrawal. When you get into good withdrawal, start with a half a film or half a tablet every 2 hours till 80 to 90% of your withdrawal is gone. Why didn't I say 100%? This drug takes 3 days to stabilize. So if I put you on 8 milligrams today, some of that will still be in you tomorrow, and you'll be at 8 plus a little bit from the day before. And the third day, you're going to have a bit from 3 days ago. So it's going to go up like this with time, 3 days. And so that will kind of come to where that's important later on. But it takes 3 days to stabilize. So I say, what you do is you simply do about, this is what I tell them. Maybe not entirely true. Okay. I'll say, I want you to just get rid of about 80 to 90% of your withdrawal the first day, because if you're 100% the first day, by the third day you'll be 120% and you'll be unhappy and you won't like it. So I want you to slightly underdo yourself the first day. But I'm also teaching a psychological thing of, can I self-inhibit? And can I just not go for the gold? Can I settle for the silver? And we're teaching a person to self-inhibit a little bit. And from the psychological viewpoint, that's an important point to start with. And then I said, the next morning, you'll take, so the first day, you'll take 1, 2, oh, I feel about there. Okay, fine. So this is, and I do this visually. I say, the next morning, your morning dose equals a total of the day before. So if you took a half and then a half, your morning dose the next day is 1. That's your dose. If that works fine for you all day, every day thereafter is the same dose. Change the story. Next morning, I take a whole one, take a whole one. I feel pretty good. Comes the evening, I feel a little dysphoric, I kind of a little like withdrawals coming back. Take the other half, make it go away. Now the next morning, I take 1.5, because that's what I took the day before. You watch me in the clinic, you watch my hands go like this, time after time. They'll see that and they'll get the concept, okay? And that's your dose. Then I'll say, by the way, you may find out that you want to take it all in the morning. I would recommend you do that the first week, see how it works out. If you're okay, fine. If you find it's getting a little weak in the evening, split your dose. Take part in the morning, part in the evening. How much it is, you figure it out, let me know. 2 weeks, they'll tell me. They'll either come back with a single dose, which works well for many people all day. Some people need a bimodal hit twice a day, and that's fine too. It's better than pumping up the morning dose till I really get 24-hour coverage, because I'll have to go about 4 milligrams higher, and I want to avoid that. Every time I go up 4 milligrams, I tell them, I'm going to take another 6 months to get you down. So methadone, we do that. What do you do with them if that isn't? Well, we had one last week with Lifeline. The person was on 120 of methadone. Theoretically, you should get them down to about 30 milligrams, stop them for 3 or 4 days or whatever they can tolerate, and then start them on Suboxone. For precipitated withdrawal, when you get a precipitated withdrawal, you might, but keep in mind, whenever you get a precipitated withdrawal, what do? Go right to 16 milligrams of Suboxone. Suboxone always wins. It may take 3 days for methadone, but Suboxone always wins. Remember, the only thing that will replace Suboxone is fentanyl. It's the only thing. So some people, we can get down to methadone to 30, and then we do that. Most of the pain patients, we can switch over to morphine, whatever it takes, and see them a month later, and they'll come in, they'll have done their own switch. That is so important. You'd be amazed how many patients I see coming in. They'll be on high dosages, they're doing it the wrong administration technique, and everyone kind of wonders, well, gee whiz, why are they on those high? I said, look, you're not even getting a fraction of what you think you're taking. Change your technique and they'll do good. Do good. So if I have 2 groups, one gets Suboxone, one gets intensive counseling, who does the best? Come on, use your common sense. Come with me here, folks. Don't leave me standing here. What does the best? What's that?
Suboxone plus cancer.
Yeah. There's no difference. Think about that. Think of how we what we're taught and how we look at addiction. So this is a poet study. I actually saw Weiss talk on this, and it just blew me away. He's from Stanford. And essentially what occurs here is they had a group of people with Suboxone and with counseling and it was a group that got pure counseling, did the worst. Everyone thought counseling with Suboxone would be the winner, and the middle person would be Suboxone alone, and we were wrong. There was counseling made no difference. So what's the success rate of, we know counseling has a success rate of about 5 to 10%. What's Suboxone? Well, you pick a number you like. If you have good relationship with the patient, you're going to get in the 70, 80%. You read numbers from 60 to 70, you pick a number you like, but it sure as hell beats 10%. And that's because it is a neurochemical disorder that needs to be treated with neurochemistry. When I read that, I already knew. Well, I'm kind of a motivational kind of guy, so I like to do that. I think relapse prevention is important. What's the effect of these? There's the study. Scary. The things that I was classically taught, the things that are so ingrained in my soul, all at once the research is saying it's not doing anything. That is so hard to swallow that pill. Remember, as a healthcare provider, and I hope the nurse practitioners and everyone else is going to do a better job than we physicians have done. If there's been a major change in how medicine should be done, what is the length of time it takes for the medical community to change and accept that? It's 15 to 17 years. And this has not changed since the cholera epidemic in London in the mid-1800s. It took them 15 years, and we haven't changed. So is there a role? Absolutely, there's a role. If the person is just wondering, God, I feel horrible, I feel terrible, I really feel bad, and you're going to counsel me? Look, Doc, I just feel terrible. Yeah, counsel me later, will you? You put them on Suboxone. People say, well, when do you first of all, I'm a poor psychiatrist, and I'll be a very poor counselor. So I say, look, we're going to get you on Suboxone for 3 months, and we'll talk about your other stuff. A lot of it disappears when we get them stabilized. But when you get them stabilized, you then have a shot at counseling being helpful. What are your problems you're having with your family? What are the problems you're having with your children? Getting them counseling, getting them therapy, getting the help with that. Then they can listen to you. They're not worried about how they're going to feel. They can listen. Okay. So, unstable environment. These are the Lifeline and Columbia River Mental Health. I get the homeless, I get street heroin. They call our clinic. We send them down there. Why? Because I can help your receptors with Suboxone, but I can't change behavior with a pill. I need other resources within my community. And so and if you're in an office practice like I am, and someone turns out to have some real funky behavior, they show up with 2 gallons of meth and someone else's Adderall tablets in their pocket, your obligation is to move them to a higher level of care, which would be organizations such as these.